All right, guys, we're going to talk about Alzheimer's, dementia, and delirium. In our Med-Surg book, we're in Chapter 60, which is on page 1443. People upstairs are moving chairs around if you wonder what in the world's going on. So 1443 in our Med-Surg, and then in our mental health book, we're on page 337. These are the objectives for these two particular chapters. You can read through these. Okay, just in general, because we're talking about cognitive disorders, cognition is a process that includes both our intellect and perception, and it is closely related to an individual's emotional and spiritual values. If we have not yet talked about the DSM-5, so if we've not talked about the DSM-5, that stands for the Diagnostic and Statistical Manual of Mental Health Disorders. It's a guideline. It's a handbook that mental health providers used as a guideline to help diagnose and treat mental health disorders. And so, yes, delirium, dementia, amnesic disorders, and cognitive disorders are within the DSM-5. Dementia is a neurocognitive disorder. It can be secondary to another disease process, such as possibly someone has experienced trauma, a brain infection, and it still could have irreversible components. The majority of time, dementia is irreversible. What we're mainly going to focus on is primary dementia, which the one that we understand as primary dementia is Alzheimer's. When we think about dementia, it's a syndrome, and this is when one loses their ability to recall information. They lose their orientation, their attention span. They lose their language skills, their judgment skills, reasoning. They have personality and behavioral changes. These individuals often just kind of fade away. They develop such issues as agitation and delusions and hallucinations. It typically, as in Alzheimer's, is a progressive disease, and that's what this particular picture is showing. A disease that is progressive in nature, and the signs and symptoms that we talked about occur. With dementia, you want to look for early signs. Often these people actually deny it. They deny the fact that they're having memory deficits and do not share it. Again, the chart on page 1448 highlights dementia versus delirium versus depression. They have confabulation, which means that they make up stories to preserve self-esteem, especially when they don't remember. They have preservation, which is repetition of phases. This often occurs under stress, and they also can have avoidance of questions. And so those are some of the things. So, we're looking for behavioral observations. We're looking for signs of alertness, signs for orientation, recent memory intact, even calculations, simple calculations, and reproduction of a cross versus a cube, which is on page 338 in your mental health book. Certainly, the most common form of dementia is Alzheimer's. It affects about 4 million adults. It's progressive, irreversible deterioration of the brain. It leads to altered nerve impulses, and it strikes the frontal lobe first. It has 3 stages, and if you look at page 449, it goes over the 3 stages of mild, moderate, and severe, and it tells you different things that are happening and different types of diversion or distraction activities that are helpful. We know that Alzheimer's can be familial. It can run in families. And we know you're said to have early onset Alzheimer's if you develop before the age of 60. What are some of the things that occur with someone who is diagnosed with Alzheimer's? If you go to page 448 in your text, 2 things. You can see a brain pre-Alzheimer's versus a post-mortem brain with Alzheimer's disease. Some of the warning signs of early Alzheimer's are listed on Table 60-3. Memory loss that affects your job skills, difficulty performing familiar tasks, problems with language, disorientation to time and place, poor or decreased judgment, problems with abstract thinking, misplacing things, changes in your mood or behavior, changes in personality, and a loss of initiative are some of the things that you see with Alzheimer's. As a result of Alzheimer's, what we know is the changes lead to a shrinking brain. So you have, as you can see in the latter stages of Alzheimer's, which, by the way, can only really be diagnosed post-mortem, you have someone who has severe shrinkage of the cortical section and enlarged ventricles. This is caused by a few different things, but one is plaque buildup. So we have more plaque buildup for someone who has Alzheimer's, more so than the normal aging process. And then you also have a decrease in the protein, and this protein, which typically acts as a stabilization device, allows the microtubules to twist together. And this causes what we will call tangles. Okay, so we have plaque buildup, more so than the normal aging process. Neurofibrillary tangles caused by a decrease in the production of a protein that helps to stabilize the microtubules, and this leads to a loss of connection between the neurons and neuron death, and you can see what happens when we look at someone's brain post-mortem and truly diagnose the fact that they died of Alzheimer's. Okay, so when we want to go and diagnose Alzheimer's, it's not easy. As we said, it can truly only be diagnosed post-mortem, but an MRI, especially if we have a baseline MRI, even in early Alzheimer's, it will show that cortical shrinkage. Can certainly do a psychometric evaluation that will identify some of the early signs and symptoms that we talked about in your med-surg book. Looking at page 446, it talks about early onset, which is familial, less than 60-year-old onset, versus late onset, which is considered older, greater than 60-year-old. Talks about the incidence, the prevalence, and genetic testing. And then if we're looking at, for instance, on page 449, and we're looking at the stages, we've already talked about this. In mild, the end of mild could be that they can no longer hold a job, plan to prepare meals, handle personal finances. As compared to in moderate, that's where we start to develop urinary and fecal incontinence. As compared to severe, they have limited speech, can no longer sit up, no longer smile, no longer hold up their head, and you can kind of see the developmental ages as they progress goes downwards. Okay, so drugs are on page 1452. Talk about the cholinesterase inhibitors. You guys have heard of these, the Aricept, the Exelon, the Cognition. You can see that they're supposed to be given at specific times. They are actually not going to cure the disease. They are supposed to help slow the progression or the rate at which people lose their memory by helping there be more acetylcholine available to transmit the messages that need to be sent. So, once again, they do not cure or reverse the progression of the disease. Okay, they might help lead to a moderate decrease in the progression or the rate of cognitive decline. They also talk about the Dementia, which helps protect the brain's nerve cells by helping to slow down the destruction of the nerve cells. But once again, they do not cure. They only help to slow the process. These might, during the first and second stage, help to improve their ability to carry out their ADLs, decrease agitation and delusions, maybe improve cognition. We want to monitor for liver function, GI bleeds,
and are there actual improvements with the patients being on these particular medicines.
Okay, nursing care for someone suffering from Alzheimer's. One obviously would be impaired memory, so we would want to use complementary therapies such as meditation, exercise, yoga. Use a calendar. Make sure that they understand what day it is. Use lists and help them to create lists at first, but then give them lists to follow. Use a med box. A med box helps them to keep their medications straight. They need extra help, so get them a caregiver. Continuity in staff is really key for impaired memory. The more often they see someone, it's possible they'll recognize them. Give them very simple explanations. Do not give them multiple things to do at a time, but give them instructions for only one thing to do at a time with a simple explanation. As far as chronic confusion, labels all over their room as far as where things are. Any hazards, we want to make sure they're gone. Light cords, throw rugs, anything that could be spilled. We want their environment to be simple. We want it to not have a lot of stimuli. We've already talked about the simple questions and the short phrases in one subject at a time. Reorient frequently. Assess and set boundaries. Once again, provide continuity in care as far as providers, and speak of familiar things. This might help to reorient them.